Hello.
Okay, good morning. It is April 8th, and this is the Senate Health and Welfare Committee meeting. This morning, we're going through some bills. The first bill, 287, an act relating to patient financial assistance policies and medical debt protection. And Jen, you're going to go through that bill with us first, and then later on we'll move on to other bills that we've been working on. So thank you for being here.
Great. Welcome. Good morning. For the record, Jennifer Carvey, Office of Legislative Counsel. This is H287, an act relating to patient financial assistance policies and medical debt protection. It would add a new subchapter in 18 VSA chapter 221, which is a pretty large chapter on healthcare administration. This one is a new subchapter on patient financial assistance. And it starts out with definitions. A lot of them are either just used in a small way in here or fairly standard definitions. But a couple that I want to call your attention to specifically are the definition on page 3 of large healthcare facility, because that's who is affected by these requirements around the patient assistance policies. And a large healthcare facility is defined as a hospital, so a hospital licensed under Chapter 43, the general hospitals, an outpatient clinic or facility affiliated with or operating under the license of a licensed hospital. So this is all of our hospitals and affiliated clinics and outpatient facilities, and also ambulatory surgical centers, which you started licensing a couple of years ago. So those are the types of facilities that are going to fall under the scope of this bill. And then the other definition I want to highlight for you is on page 4, and that is the definition of Vermont resident. And that is an individual, regardless of citizenship and including undocumented immigrants, who resides in Vermont, is employed by a Vermont employer to deliver services for the employer in this state in the normal course of the employee's employment, or attends school in Vermont, or a combination of these. And it specifies that it includes someone who is living in Vermont at the time that services are received, but who lacks stable permanent housing. So it talks a lot in the bill as well about Vermont residents.
So is it appropriate to use the term Vermont resident or for this? Just because residency requirements sometimes become so charged up.
Well, that's why we're defining it.
Yeah, okay. So it's okay to
I mean, for the most part, it really is people who live here, but it's also being used a little bit more broadly to include people who may live in a neighboring state, but work here on a regular basis, and so would be likely to receive services here.
Okay, well, this isn't going to raise any issues outside of.
I don't think it should raise any issues outside of this because it doesn't affect anything outside of just the terms of the statute.
I'll look over it.
So then starting on page 5, there is the provisions around financial assistance policies for large healthcare facilities. So those are those ones in the definition there. And it requires each large healthcare facility in the state to develop a written financial assistance policy. And it kind of sets as a floor this standard minimum compliance with the provisions of this chapter, and obviously any applicable federal requirements. So the financial assistance policy must apply at a minimum to all emergency and other medically necessary healthcare services, and that term is defined in the bill as well, using the same definition that's in DFR's Rule 0903 around insurance, health insurance. So the financial assistance policy must apply to at least all emergency and other medically necessary healthcare services that the facility offers, provide free or discounted care to Vermont residents and to people who are living here when services are delivered but lack stable permanent housing, as follows. And so this is kind of setting up both for uninsured patients and insured patients what their financial exposure would be under these financial assistance policies. So for someone who is an uninsured patient with household income at or below 250% of the federal poverty level, they would get a 100% discount from the amounts generally billed for the services received, and that results in free care. So free care for someone who is uninsured with a household income at or below 250% of the federal poverty level. And for an uninsured patient with household income between 250 and 400% FPL, they would get a minimum of a 40% discount from the amounts generally billed for the services received. So that's the uninsured patients. For a patient with health insurance or other coverage for the services delivered who has household income at or below 250% FPL, there needs to be a waiver of all out-of-pocket costs that would otherwise be due from the patient. So their experience is free care beyond what their insurance covers. And for a patient with health insurance or other coverage and household income between 250 and 400% FPL, a minimum of a 40% discount on their out-of-pocket costs. And then finally, for patients with household income at or below 600% FPL, they would receive catastrophic assistance if the medical bills for their care exceed 20% of their household income, in which case the facility must reduce the amount due from the patient to 20% of their household income. And then the policy also has to include a lot of information about kind of how to determine eligibility and the basis for calculating what gets charged to the patient. Steps the facility will take to determine whether someone is eligible for financial assistance, what they do as far as billing and collections, have an appeals process, and then provide a plain language summary of the policy. It requires the owners or governing body of the healthcare facility to approve the financial assistance policy and then kind of review and approve it again at least once every 3 years. And then on page 7, subsection D says the facility may require a patient to be a Vermont resident, so again, using that definition, as a condition of eligibility for financial assistance, that they cannot impose any requirements regarding the duration of a patient's status as a Vermont resident. Can't say you have to have lived here for 6 months in order to qualify, for example. So then there's a number of provisions in this next section 9483 on implementation of the financial assistance policy and the steps that the facility must take before seeking payment for any emergency or medically necessary healthcare services. They need to determine whether the patient has health insurance or other services, including looking at other types of coverage that might apply, like auto insurance, workers' comp, or another type of policy. If they're uninsured, offer to help to provide them with information on how to apply for and connect them with help in applying for public programs that may assist with healthcare costs. And then it specifies that an undocumented immigrant's refusal to apply for public programs cannot be grounds for denying them financial assistance under the policy. Then to provide the patient with information on how to apply for and connect them with help and applying for health insurance and private programs. So try to connect them with both public and private programs that they may be eligible for. In this case, a patient's refusal to apply for private health insurance cannot be grounds for denying them financial assistance. Try to use information that the facility already has to determine their eligibility for free or discounted care and offer them a copy of the application and help in filling it out. Then it talks about how the facility would determine the patient's eligibility for financial assistance. So using their most recent federal or state income tax return, or giving them the option to submit other documentation that DEVA uses in lieu of or in addition to an income tax return. And then it talks about what a patient who is an undocumented immigrant would be allowed to submit, like a profit and loss statement instead of an income tax return. And then the facility can't require additional information beyond those sources listed. There is an ability for the facility to grant financial assistance based on a determination of presumptive eligibility based on information that they already have, but they cannot presumptively deny. So they can presumptively grant, but not presumptively deny based on information already in their possession. They can, but are not required to have an asset test in their financial assistance eligibility criteria. If they do, it would only apply to liquid assets and not include things like the household's primary residence 401k or retirement accounts or pension plans, and sets a minimum limit on liquid assets of not less than 400% FPL for the relevant household size. And there's the process for notifying the patient about approval or disapproval of the application for financial assistance, and the appeals process. The bottom of page 10, the facility or medical debt collector must offer a patient who qualifies for financial assistance a payment plan and not require them to make monthly payments that are more than 5% of their gross monthly household income. And then there's some non-discrimination provisions. Then we get into public education and information and the requirements on how the facility publicizes their financial assistance policy, making it available on their website and patient portals, providing paper copies at no charge, both by mail and in their offices or facilities, providing oral and written translations upon request, notifying and informing members of the community in a manner reasonably calculated to reach those people who are most likely to need financial assistance, including members who are non-native English speakers, and conspicuously displaying notices and information about the facility in their offices. And then also how they directly notify individuals who are receiving care about their financial assistance policies, offering them a copy, including a notice about it in the billing statements. And then section 9485 is a prohibition on healthcare facilities selling its medical debt.
Where is that section?
That is in the middle of page 13.
Yeah, thanks. I wanted to ask you about that first.
Okay. 9486 says a person can't waive their right. So any waiver by a patient or other individual of the protection provided, or any right of under this subchapter is void and can't be enforced. So they basically can't waive your rights under this. It allows the Office of the Attorney General the same authority to conduct enforcement activities as they have under the Consumer Protection Act. Section 2, so we're on page 14 now, requires each hospital to submit a plain language summary of its financial assistance policy to the Green Mountain Care Board during the hospital FY 2025 budget review process. So that would be in the fall of 2024. And that's to give a look at what those summaries and the policies look like. And finally, the act would take effect on July 1st, with large healthcare facilities coming into compliance with those provisions not later than July 1st, 2024. So giving them a little time. And you'll hear from Devin and Mike about, I think about their respective thoughts on this process, but also about what some of the existing policies look like. So some of them may meet or exceed the requirements in here, but many will need to make changes.
Did you want to ask? I'm sorry, but
Is there a fiscal note on this?
no,
Because there's no state,
there's
no state dollars
there's
involved.
no money in it for us.
No, not for us, but it sounds like somebody's being asked to spend a whole lot of money.
So we'll wait and let's hear from the hospitals and where they are, because I know some of this already happens, and it will be interesting to see how this affects the process that currently happens.
Right.
So the questions of clarification right now for Jen. So you had a question, Senator.
I want to make some comments on that section 9485. No large healthcare facility should sell its medical debt, but probably that would probably be a comment or conversation when I'd like to hear what Devin has to say about that section.
Okay.
Because I like a lot about the bill, but I think that's problematic.
Okay, we'll hear that. Okay, and what the implications are. Okay, just a clarification for in the bill, because we went through that first part. Is there anything in here that that defines what all is included in the medical debt itself? Does it include any transport services, ambulance, or other by the hospital?
The definition of medical debt is debt arising from the receipt of healthcare services.
Okay.
Clarification, under the definition of healthcare facility,
Yes.
large health, it's outpatient clinics, ambulatory surgical centers,
They're there.
what isn't included?
Birthing centers.
Birthing.
So independent providers' offices, care centers,
But all our small hospitals.
all of the hospitals, yes.
All of the hospitals. And if and so,
And they are required under law now to have, under federal law, to have
Yes.
financial assistance policy.
yeah, no, I'm just trying to wrap it. So part of the service is the charge the doctor makes, so it's how do you wrap the surgeon's fee?
I'm gonna defer to Devin.
Yeah, well, let's get some testimony.
I'm trying to
So,
figure out if this is new, if it exists,
yeah.
what kind of a burden we're putting on hospitals.
Well, here's the way I think about it, and then we can hear from Devin and Mike, but I know that when my husband had his emergency gallbladder surgery, the financial services people came around and so talked with him about what his insurance situation was, and then what was left over, and what any help that he or we might need in paying for the surgery. And fortunately, we're okay with that point, but so there are services already, so we should probably hear from
It's the
folks.
counseling that seems to,
Huh?
it's the counseling that seems to vary.
Yeah. So I think we're good. I'll be right over the goal. So Mike, you're up next,
I'll go next.
and then Devin. So thank you for being here.
Good morning, Mike Fisher, Care Advocate. I think the major sort of highlight news flash to say about this bill is the original process. Healthcare Advocate's Office has been working on this issue for a long time. We had always planned to do a legislative approach that got postponed a year by COVID. And this year, I think, further affected by the dynamics of this year. And it became clear to all of us, including me, and I think the Hospital Association and the House Healthcare Committee, that the only way forward for this bill was for a collaborative process between the Advocate's Office and the Hospital Association. Devin and I worked hard, and we both gave up a lot of stuff, which I'm not going to talk about now.
That's good.
But we also found consensus on everything that's in front of you. Generally, I'll say we got a few more things included in the bill. With an agreement that we postpone the implementation date for an additional year. Give the hospitals time to wrap their heads around it and adjust their practices. So that's sort of one major access point that we played with in order to find the consensus we did. A couple of basic things. Who does this not cover? Question. About 40% of the healthcare dollar is spent in the hospital system, in the regulated hospital system. So this affects that group. The majority of healthcare spending happens in private practitioners all over the state, and they are outside of the scope of this bill. I'd love to do a bill about that, but that's for another day. And I think the other major concept to say is that our goal all along was not to increase uncompensated care. Let me just talk about a few terms for a minute. Uncompensated care, there's lots of ways of measuring it, but one basic way is these are charges that are billed for, that are services that are billed for that are not collected. And so a big category of uncompensated care is the care that's given away by hospitals as free care. In 2019, that's about $45 million. Hospitals said, you don't have to pay us, you're too low income, we're gonna not send you a bill. We're gonna give this as free care charity here. Also in 2019, hospitals sent out about $85 million worth of bills that they didn't collect on. So we call that bad debt or medical debt. Let's just use plain language. People got bills they couldn't pay or didn't pay. And so our goal all along was to play with the line between free care and medical debt, not to increase the whole pie. We don't want hospitals to have to shift more costs off to ratepayers. We just want to count people. The goal here was to count people accurately. So that's an important concept, and we kind of can't go on until we make sure we understand that. It's just very, very important. Any question about can hospitals afford this? The answer is they already are. So I want to emphasize every entity covered in this bill is already required to have a free care policy. Most all of them, all of the hospitals, all nonprofit hospitals are required to have them by the Fed, by the IRS. The ambulatory surgical care centers are required by state. I think you were actually 2 years ago or so. What this bill does is normalizes it across the system. The Feds say everybody has to have one, and the Feds say a lot about how they have to make those plans available to people, posted and whatnot, but they don't say anything about how do you define residency? How do you define household size? How do you define household income? And that, as well as the minimum standards for financial eligibility, is the main work of this bill. I think those are the main points I wanted to make.
Okay. So the question that Senator Terenzini raised, which he's probably going to ask of Devin, I think is something you may want to comment on. Yeah.
So we don't believe any hospitals sell their debt to a debt collector, a debt collection agency today. That doesn't mean that they don't employ a debt collection agency to help them find people, communicate with them, and so on. I will say, a little bit from the consumer's perspective, I'm not sure. Well, there's a few things that matter a lot, but for the person who's being contacted by a debt collection agency, they're being contacted by a debt collector. That's all they know. They don't know who owns the debt. And I'm not sure exactly if this bill satisfies it. And I really want to commit myself, continue to commit myself. This is a consensus bill, and we're going to continue to operate as a consensus. So to the extent that the committee has ideas of things that they want adjustments to the bill, that's great. We should talk about it. But Deb and I are being team. But hospitals do employ debt collection agencies all the time, and we'll be able to continue to do so.
So you're saying no hospital in Vermont right now sells, let's call it bad debt, but medical debt or whatever you want to call it. None of these hospital facilities are selling off. They've attempted 30, 60 days to get payment, and then they don't sell it off to agencies. You're saying?
That's my understanding. Is that nobody does.
I certainly believe you. You know more. Devin knows more than I ever will. But to me, it doesn't make sense that a hospital wouldn't, because if they could sell that bad debt for 40 cents on the dollar, that's 40 cents that they're getting back. That they're probably not getting any of it back. So why wouldn't a hospital sell that medical debt to somewhere else and try to recoup some of their money? And especially how fragile hospital budgets are right now when you look at Rutland at $7 million deficit and so on.
So Devin should certainly speak to it. My understanding is that hospitals collect pennies on the dollar of bad debt. And I also think I think, you know, my advocates fight with hospitals all the time around particular bills, but I gotta say on a high level, I don't think Vermont hospitals want to be in the world of, you know, aggressively employing somebody or selling a debt in such a way that it's going to be aggressively, that their patients are going to be aggressively approached to that. So that's sort of the frame of my understanding of it.
I'm just surprised when
Yeah.
you know, I just assumed that they were getting something when the debt collector called.
So that's what I said. They may be getting something. They employ, they pay a debt collection agency some money. The debt collection agency goes out and contacts people and attempts to get them to pay, and some dollars come in.
But they would, if this bill passed, they would still be allowed to employ their own debt collection agency.
They're not selling off their debt for 40 cents on the dollar.
You know, the main dynamic that I want to minimize, I think everyone wants to minimize, someone goes and gets some care. A year later, they get a bill, and they say, you know, I'm going to put it a year out. So it's too late to do much about it. And the person says, wait a minute, how come you didn't bill my insurance company? And so they call the hospital, and the hospital says, well, go call the collection agency. And they call the collection agency, who says, I don't know anything about billing. You need to talk to the hospital. And, you know, that's the kind of dynamic that we don't want a runaround. People to be stuck between. And you know, great hospitals with great systems still make mistakes. And people still get stuck in those dynamics.
Well, I think I'll move off from this one, especially if Devin. We're okay.
Are you done, Sam?
I'm good, thank you.
Okay. So I had talked to you about this bill a long time ago, and before I saw it, but it doesn't mention the free clinics in here at all. And I know that a lot of the work that I know personally, a lot of the work that the free clinics do is exactly this: get people eligible for free care. And I can't speak to current situations, but the open door clinic often, at least used to, and I'm assuming they still do, get people qualified for free care at Porter, and then Porter, you know, grants the free care based on the work that the free clinic has done to assure someone is eligible. I don't see any language in here about the free clinics and their work and how that would be integrated into this. And I think most hospitals, not all, work with one or more free clinics.
So that one,
Okay.
you're right, it doesn't address that, and if there's a place where that makes sense, then, you know, we'd be happy to look at it. I think lots of different entities work to help people get connected with people's policies.
Yeah, absolutely, they do. I think the free clinic, well, the free clinics also provide care
Yes.
that sometimes then, you know, integrate with the hospital in a way, like they'll be seen in the clinic, but they'll get an X-ray at the hospital or something like that.
Somebody will correct me, I think that the Porter open door clinic relationship is maybe a little bit different than other places in the state. I think.
It is definitely more integrated and collaborative. At least it was when I was there, and I think it's even more so now. But I don't know. I think that other hospitals also have really close relationships with their free clinics. So maybe Deb can address it a little bit, but I don't know if I think Steve Meyer is still working with them. I don't know if he's looked at this. Oh, he's not. Okay. I don't know who's working with them anymore, but if they've looked at this bill to see how it.
We have not reached out to Olivia Sharrow, who's now in that role, but would be happy.
That might be helpful. I mean, given the time that we have here, if you would mind reaching out and then answering any questions that Senator Hardy has about that.
Yeah, and I'm happy to talk to her since I have personal experience with it. So.
Go ahead.
Thank you. This doesn't cover like urgent care centers or any of those those are all private.
We don't have any of that.
It would cover the urgent care centers that are connected to the hospital.
Yeah.
The independent ones.
But the independent ones are not.
Okay, any other questions for Michael Fisher?
Thank you.
Good, all right, Devin, fine.
Thank you. Devin Green from the Vermont Association of Hospitals and Health Systems. And, you know, as Mike pointed out, this was a collaborative process. And I think part of the process was standardizing some financial assistance policies. So as Mike said, hospitals are required to have these policies in place. And a lot of them were close to these targets, but not quite there, and they were different. And I think the main thing was there were lots of different requirements around residency and, you know, do you need to be a resident of the hospital service area or can you just be a resident of Vermont? And so there were variations throughout the state in some of these policies. So there was an effort to simplify and standardize this a little bit more so that we don't have one person eligible over here but not over there. So I think that is a big help. There were also different definitions of household. It could range from anyone who is in your house to tax household. And we've landed on, I think, a really good and more simplified definition of household as well. So in terms of the free clinics, I think one highlight of this is it should be, you know, now that this is a bit more standardized, it may be easier for the free clinics to go through that process of figuring out eligibility. Now, if it's just a resident of Vermont, you know, they can be eligible. They don't have to figure out where exactly the person lives and if they're in the hospital service area or anything like that. So I think that is one way where that can help with the coordination of having people eligible for this. I think, you know, what Mike pointed out was that we are waiting until 2024 to ensure that this is implemented. I know Mike has high hopes that this is not going to impact our finances at all, but I want to make sure, which is why I want to give this a little bit more time. I put a document up, or Erin should have put a document up.
Yeah, we have it.
Okay, so I just wanted to point out that one thing that hospitals have is a federally required disproportionate share hospital payments. So the purpose of this is to go to these uncompensated costs and try to make hospitals whole. Vermont has an allotment about 50 million that we could take advantage of from the Fed, so we could get federal match and have a total of 50 million. We were originally at 38 million a few years ago, and then due to both legislative and administrative cuts, we are now more at 22 million, if I have that right. And so this, you know, if this does have an impact on our finances, we would come back and we would be wanting to talk about this funding a little bit more. Again, you know, we don't think it will. We think it's just going to standardize things, but that's why we have the 2-year time. So we can really dig into it a little bit more and figure out if it will have an impact to our finances. All this is also to say that our neighboring states take much better advantage. They have more generous federal allotments. Maine has about 200 million that they get, and New Hampshire gets 392 million, and even DC gets 107 million. So we already have a small allotment at 49 million, and then we've reduced it even more to this 22 million. And again, that's matching funds. So I just like to point out the interplay between that and the STISH funding. And then finally, with the selling of the debt, I think the answer to your question, Senator, is hospitals have an ongoing relationship with their patients, and there is a real impact on debt collection and then patients being willing to seek care. And when you do sell the debt to a debt collector, instead of just having the debt collector try to collect it, where you have control there and you can ask them to stop, and once it's sold, it can be sold again and again and again, and they could be collecting for a very long time. And so I think a lot of our hospitals, or all of our hospitals, have calculated that we don't want to give up that patient relationship by selling the debt.
Do you have anything more?
No.
Okay, so Senator Hurd.
Okay, can you, what is DSH again?
Disproportionate share hospital payments.
Why is our allocation so small?
Oh.
Okay, I knew that was gonna happen.
That is like some arcane federal calculation, they brought these payments on, and so they looked at a variety of factors when they brought the payments on years ago, and then they just sort of locked into it. And so that is where we were locked into many years ago.
By the feds?
Yes.
Who decided it? Is it CMS? Who decided it?
I don't know.
Can I go talk to them? That's ridiculous.
Well, we don't even take advantage of our current allotment. So, we have a
Why
current
not?
allotment of 49 million, and we only get 22.
So what's
Why
it
not?
based on?
This would be a good topic for the finance committee to take
It's
up.
about appropriations, but
Right.
the state funds have to match the dish payments. And some years, that is a really big thing at the end of the year when you're dividing things up.
And to be fair, a lot of this, if you're looking at the chart and you look at the years, you'll notice that we had high hopes for health insurance and healthcare reform, and the number of uninsured going down.
Right.
And so we thought, okay, we can ratchet this down a little bit because everyone's going to be covered and able to pay. And we just haven't seen that play out, I think, primarily to, high deductible health plans and other variables.
And the free clinics, I mean, the thing in the process in the bill is much more complex than what free clinics usually use.
Okay.
And so that's where I'm a little concerned that if hospitals start telling free clinics, you have to go through this process, it will actually make fewer people eligible because it's way more complex. And that's why I had asked that you work with the free clinics to really make sure this is really aligning with what they do.
Okay. Because I think the hope is to simplify. And if that isn't the case, we can come back before it's implemented and streamline this further, simplify it further, because we don't want that to be, the reason we're putting this date out is because we don't want unintended consequences like that. So we're gonna work on implementing it, work with our partners, and if we see issues that come up, we'll be back to.
I guess I would really like to hear from them before we pass the bill.
Let's do that.
I'm really concerned about that. And so if it is true that I want some language in there that assures that you'll come back to it rather than just, I trust you, Devin, but I want more than just your word of mouth, or your word, because it is more complicated than.
So what I would suggest is this, let's have Mike and reach out to the free clinics initially and see what information we get back. And then it may be, I think the solution is what you suggested, and that is to add some language that we would come back and review the effect on free clinics. But I'd like to hear.
Can I ask a clarifying question?
Yeah.
Senator Hardy, is your concern that the requirements in the bill, like hosting and all the requirements about making it available would impact the free clinic practices?
Well, the documentation of things, like I think could be problem. A lot of people who need free care just don't have the documents that you need. And so, particularly when you're working with,
Delivered at the free clinic.
yeah, and so if the care is delivered at the free clinic, that's one thing, but often, the free clinics will need an X-ray or blood work or, whatever, and they'll transfer, they'll work with the hospital and get the care for those things.
Who's responsible for that and for documenting the patient and the services? I think that's what you're asking, so that does.
That's not what I'm asking. Generally, what happens is that the free clinic will determine that somebody's eligible for free care.
Yeah.
And then the hospital will say, well, the clinic has determined they're eligible for free care, so they're eligible for free care because the clinic has verified their need. And sometimes a little bit more documentation is necessary, and obviously charts and all that stuff, but I'm a little worried that then if the free clinics say this person needs blood work, that the person would then have to go through it all again with the hospital.
Yeah.
And it would complicate things. So
I don't think that changes that. I think this, when it talks about determining the eligibility, it says, you can use the most recent federal or state income tax reform. You can ask for other things. You can use other documentation. Mm-hmm. The requirement for hospitals sort of set by Medicare is that you do need, the hospital itself can't make the determination without verification. Mm-hmm. So if this meets the sort of other documents, we have in here other documentation. I think the free clinic saying that someone has met would suffice the other documentation requirement.
Okay.
Yeah.
Okay.
But the right answer is we'll talk to those.
Okay. That would just make me feel better before voting on this because I want to make sure.
Yeah.
We're taking care of
We want to protect them.
Yeah.
So it was good point, and perhaps we can get something in writing that you could send in so that we can see what the response is, and then we can decide, do we need to hear directly from free clinics and maybe sort something out. But
yeah. I know time is tight. I just.
Yeah, all they do is size letters.
Huh?
What about forward?
The size letters.
Thank you. Just keep me in the loop. Yeah. Thank you.
Oh.
Last name is Goldfinger. I'm forgetting her first name.
Sorry, I missed that.
I'm gonna leave it to Michael to reach out and Devin and to coordinate the response so we know the effect on patients and hospitals.
Madam Chair, I forgot one other thing that I meant to say, and I can say it from right here, and that is, I also supplied another document to you that is sort of background. And it is the announcement of a new webpage that we created, vtmedicaldebt.org. And it is our ongoing project to tell stories, to help Vermonters tell stories about medical debt and how it's impacting their ability to get care. And so I invite you to take a little time and look at the stories from your counties.
Is this related to the survey that you put out?
It is.
Yeah, okay, I thought so. Look familiar.
And just because I can see it here, I want to say the word cloud that's at the base of that, the problem is that it looks too slick. It looks like we took it right off the internet. That's actually a word cloud from the stories that came to us. So.
Slick. Okay.
You're not slick.
Not me, my staff.
Okay,
Thank you.
so Devin, we're good?
We're good.
Okay, thank you. All right, so we'll look for the information coming back regarding free clinics. Good question. And so that we can smooth over, hopefully, that process. And then we'll come back to this as soon as we get that information. Thank you.
Thank you.
Thank you.
Now we can return to occupancy with, all right. Good. So we have 10 minutes before we get to our next topic, and so we're good with that, Bill, but we need to hear.
Yeah. And that would be great.
And then we're looking at our next, as Jen, we have two bills that we've been looking at. I I don't know what your day involves today, or how long are you here with us? Let's look at those bills and maybe, you can let Lois know that.
Yeah, I'm good to be with you. I'm sort of trying to keep there's a bill up there for reading on the House floor right around now, but I don't expect any issues with it, so.
Let's go to H 153,
Okay.
and then we'll move on to,
Prepare a little tiny amendment for you, just on the
Okay.
dates.
and we have it, I think.
Yes. H 150 is the Medicaid reimbursement rates for home and community service providers bill. And for the most part, we had not discussed changes yet, so the only thing I brought to you, just an amendment that would just move the dates in the bill out by a year. It's a 2021 bill, and so the dates have either already passed or almost passed. And the bill has passed by us.
Okay, so the bill has passed. Can you give us a high-level reminder of what we have here?
Sure.
There's no, is there an appropriation in here?
There is an appropriation not specifically spelled out, but I believe there is a fiscal note. Because the study to be done, the rate study to be done in section 4 has some costs associated
Okay,
with it.
right, okay.
So sections 1 and 2 are really the definition of section 1. Section 2 is directing the Secretary of Human Services to determine the payment rates for providing home and community-based services, and to report on them annually to various committees, including this committee as part of their budget presentation. And it requires some rulemaking as well about the methodology for both the rates and also coming up with an annual inflationary rate adjustment. And section 3 does the same thing, but for the designated and specialized service agencies. Section 4 directs DEVA in collaboration with others in the Agency of Human Services to do a rate study for home and community-based service providers and providers of substance use disorder treatment services, and to report the results of the rate study and findings and recommendations to this committee and others, and to the Secretary of Human Services. And so the amendment would just move that report date from January 15th, 2022, which is already passed, to January 15th, 2023, and then the effective date section. For the most part, it takes effect on passage, but there's a rulemaking date certain of honor before July 1st, and the amendment would change that to 2023 rather than 2022.
Okay. Yeah. Actually, this is pretty opportune, given that maybe some of the recommendations we'll be making for the budget will go hand in hand very nicely. I hope, well, let's hope the bill passes and it's not, who knows what. I was gonna say, put into the big bill. Okay, so committee thoughts here, discussion?
Nolan popped up.
He did.
Very good.
We just said fiscal note, and there he is. Nolan, did you wish to comment? Good morning.
Morning, how are you?
Good.
Do you want me to comment?
Yeah, just quickly, please, that would be great.
There is as Jen mentioned, there is a fiscal note. And I'm just reading it now because I'm trying to remember what it is the bill does. Yeah, no, I mean, there is some money that would be needed, but there is no appropriation in the bill, in short.
Do we have a guesstimate of what would be needed in order to accomplish the work that's in here?
Yeah, it's confusing. If you go to the fiscal note and you go to the second page, it basically according to AHS, there would be 2 FTEs that would be needed, but the amount would depend on whether this was approved by CMS to be able to use the home and community-based enhanced FMAP.
Yeah.
And so if it's approved, you would only need 50,000. If it was not approved, you would need 100,000.
Got it.
Nolan, wasn't there something in the BAA that was related to this bill?
I do not. Yes, I have that on the middle of the page. There's the first part was there's initial contractual needs of $390,000. But the administration, AHS, requested that coverage again as part of the enhanced home and community-based FMAP. If those funds are, so yes, they put it in there, and it's assumed as part of BAA. So you don't need an appropriation for that particular piece. But they felt that there was 2 FTEs that were needed that aren't in the budget anywhere.
Do we have that? Can you resend that fiscal note?
I just posted.
Did you just post it? Okay, so we just need to refresh.
Yeah, and Aaron, you should post one that says updated 325. I had done. What's that?
I just took the one from your website, JFO website.
Okay.
So-
Because I'd done one last year and then I updated it about a week
This
ago.
is the right one.
Okay.
Did you get it? I'm trying to refresh.
Yeah, I had to refresh 3 times, so.
Yeah, that's what I'm doing.
But it is,
Oh,
it
here it
says
is, okay.
325 updated.
Okay, good.
Okay, as long as it's the right one. So, I mean, you know, you could pass the bill and with a note to appropriations, you could put an appropriation in it and let them strip it out. You could get the administration in to follow up on this and say, can we do this? And you come in for, I don't know the next steps on this.
I think having the fiscal note travel along with the bill to appropriations is probably the most efficient thing that we could do at this point. And then
Appropriations will take this bill even
I know,
even without the appropriation.
of course they will, and it may well be that it ends up being a part of the big bill because it does enhance some of the work, other work that we're doing. So I think that's probably the best route to vote it out and send it along with a fiscal note. We don't need to become the appropriations committee.
I think as long as they know that there's a potential cost with it. Sometimes you put the appropriation in just to flag it for them. But if you're clear and make it known to Senator Kitchell that there's an
We'll let her know. Yeah.
I think we need to let Secretary Plummer know.
Yeah,
You
just
may-
have to let
you may
the
catch it
secretary know.
perfect.
Yeah, that's good.
That way they'll know it has to go to appropriations at all.
Okay, so then our decision here is to leave the bill as it is with the proposed amendment that Jen has brought us. And then it'll travel along with a fiscal note. And then we'll let the secretary know that appropriations probably should look at the bill. And that we will have done our work. So, discussion. I'm looking for a proposal.
I move that we amend the bill as
With draft 1.1 dated 4/7/22.
Okay. Discussion. So the proposal is to amend the bill, H-153, as moved by Senator Hardy. Discussion.
Is there an amendment sponsored for this one?
Yeah, that's right there.
On the committee.
So, yeah, just change his dates.
Just want to make sure I didn't pay for it right.
Otherwise, we're gonna send the debt collectors after you.
Please do.
Okay. Go ahead, Senator Clerk.
Okay. Terenzini, yes. Senator Hooker,
Yes.
Senator Cummings,
Yes.
Senator Hardy,
Yes.
Senator Bland.
Yes.
500.
Now we have to have a motion to move the bill as amended.
So H 153 as just amended.
Okay, discussion? Okay, go ahead, Senator Terracini.
Oh, okay, all right. Terrence, yes. Senator Hooker.
Yes.
Senator Cummings.
Yes.
Senator Hardy.
Yes.
Senator Lyons.
Yes. So Senator who would like to report this? Okay,
Sure.
all right. Good. And I'll put it in your hands to let Secretary Bloomer know. And we'll carry it along the amendment and the bill from the House to the Secretary with your signature and a 5-0. Amendment is what goes in the calendar. Yeah. Okay. All right. So let's take a little time here on H 266 and see how far along we get. H 266.
Let people know they're waiting, it's fine. They know what
Do you
they're doing.
need interpreters or anything for 266?
No, just using your.
Okay, so turning to H 266. This is an act relating to health insurance coverage for hearing aids. And we do have an amendment on this. Some of the provisions in the amendment came from some fairly technical requests from the administration, just based on the language, making the language more accurate, and then the others are based on things from this committee. So everyone have the documents?
We have the amendment, draft number 2.1,
Great.
and it's all highlighted for us.
Well, right, so there's highlighting in the sections where I struck out the whole section and put it back in so that you could see the changes.
Good.
So we don't really need those in there after
Got it.
this, but I just wanted you to see. So the first instance of amendment would strike out section 2 on essential health benefits and that report, and put it back in with some changes. So those are the changes indicated. So this would still have it by November 1st, but this would now not just be DEVA, but would be DEVA and DFR. So Departments of Vermont Health Access and of Financial Regulation would provide an update to the Health Reform Oversight Committee regarding the status of the state's application to, and then they wanted to specify that it's the Center for Medicare and Medicaid Innovation within the Centers for Medicare and Medicaid Services, to modify the essential health benefits in the benchmark plan to cover hearing aids. So those are, as I said, some fairly technical fixes. The result is still the same report on the status of that effort. Similarly, the second instance of amendment, which is amending section 3, and that is where you are codifying the Medicaid hearing aid coverage requirement. They just wanted to specify, DEVA wanted to specify that it's actually the Agency of Human Services technically that's the adopting authority under the Administrative Procedures Act. So it would just say, and other services as defined by the Agency of Human Services by rule, not the Department of Vermont Health Access. Then we get into some more substantive changes. The third instance of amendment on the top of page 2, in the definition of hearing aid for purposes of the large group health insurance mandate. This would take out the specific exclusion of cords for what is defined under hearing aid, based on some concerns about what that meant and whether that might inadvertently sweep in either parts of hearing aids themselves or something that was necessary in order for the hearing aid to be useful. The fourth instance of amendment is also in that health insurance coverage section. And this would strike out subsections B and C and put in new B and C. And this is where you could ask to align more with the language in what's being pursued for the benchmark plan. So this would still require a health insurance plan to cover the cost of a hearing aid for each year and the associated services. But then it would specify in subdivision 2 that a health insurance plan may limit coverage to not more than 1 hearing aid per ear every 3 years, except that a plan shall cover the cost of 1 or more new hearing aids for a covered individual prior to the expiration of a 3-year period based on a hearing care professional's determination that a new hearing aid for 1 or both ears is medically necessary. And then it's my understanding from DFR that that is really how it would likely work in practice for the benchmark plan as well, that limitations like the 3-year limitation can be overridden in the event of medical necessity. So that's inconsistent. And then I put in subsection C that subject to the limitations set forth in subdivision B2 of this section. So subject to that requirement, the coverage provided would be limited only by medical necessity. And then somebody could still purchase a more expensive option if they wanted to get it.
Sure.
And I did run this language by DFR and Blue Cross, and they did not, they seemed to think it was consistent with their understanding of what the committee was looking to do. All right, and then finally, we have a new 5th instance of amendment, and I think this was based on some recommendations from some members of the committee, so it's in here for discussion. This would add a new section to be section 5 that would direct for the collective bargaining negotiations for the successor agreements to the collective bargaining agreements taking effect on July 1st of this year. The state and the collective bargaining representative for the state employees shall consider aligning the hearing aid benefit for the state employees' health plan with the hearing aid benefit set forth in APSA section 4088L. So not requiring that to become part of the plan, but directing them to look at whether that's something that they would want to do for the next contract, not the one that's about to take effect. And then we would renumber section 5 to be section 6.
Okay. I think that is a good way to put this in the bill, the consideration.
Because originally they were carved out.
They were carved out. And we heard from them. We did not hear from NEA. We're not going to. They can still do
They
it.
can operate, they can also consider it.
They can still consider it. but-
This was an attempt to, because the state employees have already, they're just about to start a new one, and so we didn't want to mess with their current.
Okay, so the proposed amendment here, how are folks feeling about that? Anybody not happy?
I have reservations about the section 5, just.
Which is section 5?
That's the new one, yes.
Just any kind of messing in collective bargaining.
Yeah.
Especially since we're now leaving teachers cut out. But since your property taxes are paying for the teacher's health care, that I don't think we need to tell them that somebody else is getting a benefit and they might consider it.
They did ask us to include them completely, so this is a.
Yeah, they did, but they also, somebody must have asked to have them carved out.
I think that was the determination because of the cost, you're.
Yeah,
absolutely right.
well, that's.
Yeah.
We're gonna pay for it, and yeah.
Well, okay, so your interest then is not to include this section?
The collective bargaining system is highly structured, it's highly complex.
Yeah.
And I don't think they need the legislature telling them what they need to bargain over.
Yeah.
Consider. I think they know perfectly well that hearing aids are going into large group things. And if it works, if state employees want it, then it will it will be in there as part of
It'll
the
be put on the
bargaining,
table.
and if teachers want it, it will be in there as part of it. I just think it's dangerous precedent in the legislature.
My other thought on that as you're talking, and it hadn't escaped us, I think that if this is in here, this might move the bill to another committee for review. I have not talked to the chair of GovOps about it.
So
Get it through there.
if there's a concern on the part of the negotiating units, and is it better to just be silent on, not have them carved out, or?
Well, they're not included in the bill. I mean, you haven't done anything that you have carved out the teachers' health plans because they otherwise would be required to follow the state mandates. Based on the language that is in your existing bill, I don't think you are silent on state employees, which means they are not included.
Well, I think we've heard very little testimony on this. We have heard testimony, but very little. We do know that there's significant cost should it be put in place. And so I'm leaning toward Senator Cummings right now and with her concern about this, and thinking that we could also send a letter from our committee to AHF, whoever administration, or I think we may communicate. There are different things we can do and communicate with our GovOps folks and see what their thoughts are. Let's go ahead, Senator Hurd.
I think the main reason why I have concerns with being silent to it is if we're requiring all of these private plans and then the state funded Medicaid plans to provide this benefit, but then we ourselves are not doing it for our own employees. There's a lot of hypocrisy to that. And I don't know that we know that it's gonna be super expensive. Nobody's costed that out. And
We did hear that. We did hear it was gonna be expensive, but it's different.
I think we've heard a lot of people say it's gonna be
Yeah.
expensive. We haven't gotten.
We don't have the
fiscal
fiscal.
note. We don't know exactly. Nobody's looked at how much it's gonna be. So, I mean, that statement of, shall consider is pretty
bland.
weak. And intentionally so, no criticism.
We could say
We told you to say that.
We could say may consider that.
So I think that, I think they're probably gonna consider it anyway, but I also think that there is a possibility that that the sort of negotiators don't consider it because they're not prioritizing the needs of people with hearing loss.
Yes.
And that this is saying, we want you to prioritize the needs of people with hearing loss among state employees because we just required it for everybody else. We want you to consider it for next time because we think it's a priority to ensure that people who have hearing loss have the ability to get a hearing aid.
And we understand that currently the benefit they're getting is once every 5 years. Up to what, 1,500?
Right, which has not started yet.
Yeah, which hasn't started yet. This is brand new.
I know, we have worked so long and so hard to get hearing aids covered at all. I have seen things vetoed for lesser reasons than the legislature is messing in the collective bargaining. And I would be more concerned about teachers because this administration took over a statewide teachers negotiation for health care. For the good this is going to do, and I feel like it's kind of patronizing for us to tell them what they should think about. Just not worth the risk to me.
So here's my suggestion. I'm gonna suggest that we have another hour and 15 minutes. I'm going to suggest that we put this one on hold and move on to the testimony that we have scheduled for H720. And then at the end of the day today, we'll come back to this. And while your hamsters are turning in one direction, they can turn in the other. And we'll come back to this.
I mean, if you want to just pass the bill out, it's fine. I mean,
No, I'm not.
fine with taking the section out. I think that.
No, I'm
there's-
ambivalent about that. I'm listening to both the discussion here, and I think let's just put it on hold for just, for about 45 minutes. We'll be fine. Yeah, that's good. So, and we should move on to H720, about which we've taken significant testimony, and we have a couple other folks who have asked to testify. So we'll.
I'll do that.
Okay, thank you, Jen. Who have asked to testify, so we've asked them to come in and give brief testimony, and then we'll move on.
You ready for me to look at it?
Please, yeah. Is everybody here?
They're here.
All right, good morning, everyone. So we are taking up H720, an act relating to the system of care for individuals with developmental disabilities. And as I indicated earlier, we have taken significant testimony on this bill. And we're very pleased that we have Susan Yuan, a parent, with us today. So Susan, welcome. And we look forward to your testimony. I think you did send us written testimony that we have on our webpage.
Yes.
So why don't you go right ahead, introduce yourself for the record, and we will welcome your testimony.
Thank you very much. Good morning, and thank you for this opportunity to testify. My name is Susan Yuan, and I live in Jericho. I have a 48-year-old son served by Upper Valley Services, and I have been involved in policy work with developmental services extending back to the closure of Brandon Training School. I urge you to adopt the language of H720 as it reflects input from many stakeholders. In the 38 years I have lived in Vermont, I can't remember a time when more families have expressed concern about developmental services and about their own voice in influencing changes. My testimony today is bolstered by ideas from an active group of families in southern and central Vermont, including people who self-manage their services. Families of young adults with intensive needs are worried, really worried, about living options. The shared living model, while cost-effective and successful for some, is not the answer many families are seeking. They want at least a range of options, and H720 offers pilots for different models, which is a reasonable way to move forward. It also includes a position for a residential program developer to expand the options available. I rejoice at the promise of more quality service reviews. While I believe that most agencies are working very hard to provide quality lives for the people they serve, for many years, we have had to accept this largely on faith. The requirement that there be annual quality service reviews of agencies is absolutely essential to doing our best to ensure the health and safety of the people served. The department provided information that 5 positions would be required in order to accomplish this. As a vulnerable population, individuals with developmental disabilities and their families have the right to expect at least annual site visits. Confidence in developmental services has been eroded both by persistent shortages in the direct support workforce and by the payment reform initiative of Dale, which has demonstrated a lack of real commitment to stakeholder participation. On the first issue, workforce, this was something that a hard look at the demographics of Vermont should have foreseen. More than 20 years ago, I served on a short-lived work group that predicted inadequate numbers, both for direct support workers as well as caregivers for people who are aging. The problem was identified and then the effort ended. This, rather than payment reform, is where the energy of Dale should be focused. I have served for 4 years on the steering committee for the payment reform, and I still can't figure out why we are doing it. Yes, an auditor's report in 2014 identified that accountability within developmental service agencies was too loose. Procedures needed to be tightened to establish whether people were actually receiving the services for which they were budgeted. That is fair, but not that hard to fix. Rumors of inequity among service recipients circulated, but they seemed to be based on anecdotes rather than data. Appeals processes have been available all along. So why are we investing all this energy? What problem are we solving? Stakeholder involvement in the payment reform process has been abysmal. The true stakeholders, who are people with developmental disabilities, have not had plain language materials to understand what is going on. As a result, for the most part, even when they are listed on committees, they have not participated. They have better sense than to participate when their voice is not valued. Some of the rest of us have participated on committees in good faith, only to come to the conclusion that the decisions had already been made. We give our input and are informed about the decision with no attempt to build consensus. For example, on the assessment work group, 2 of us have our doctorates with solid understanding of assessment, and others are well-informed participants, including at least 1 teacher. I am a fellow of AAIDD. We argued strongly that the use of AAIDD, that's the American Association for Intellectual and Developmental Disabilities, the use of their supports intensity scale was incomplete for assessing the needs of Vermonters with IDD, regardless of the fact that it was standardized. There also needs to be a context assessment, which would consider the environment in which people with disabilities live and operate, and the appropriate supports for functioning successfully within that environment. The decision was made to move forward with the CIS-A. A 5-year contract was entered into to conduct the assessments, and because of that contract, our efforts to slow the process down and make sure we are on the right track have been disregarded. As a result, this is Vermont. Grassroots initiatives have sprung up among people with real investment in developmental services. Family members, agency directors, past and present, people who have served on the State Standing Committee of Developmental Services for a cumulative number of at least more than 100 years. People with knowledge and experience of payment reform in other states, including its disasters. We are taking the things that have already been decided and building an alternative process plan that meets the CMS requirements, satisfies our standard of keeping the individual receiving services as the focus of the process, and which assures equity and fairness without the use of mechanical algorithms. We do not trust the payment reform process without the oversight of the legislature. The reason for such oversight is consistent with what occurred when Brandon was closed. And this new systems change process is every bit as large as Brandon. Dale has not involved stakeholders in a meaningful way thus far, and legislative oversight is necessary for this practice to be improved. Every member of the legislature will have constituents who are affected by these changes. It is reasonable to expect elected leaders to be the decision makers over this type of fundamental change in the way people with intellectual and developmental disabilities in Vermont will be served and treated in the future. Thank you.
Thank you very much. I appreciate your comments, and it sounds like you're in support of H 720 going forward.
Yes.
Okay. Just checking. Susan, thank you. Any questions for Susan Warren? Okay. Thank you, and you can stay with us. And thanks for sending your testimony in ahead of time. It's extremely helpful to have it. So Beth Seitler is here, and Beth, why don't you introduce yourself for the record? It's good to see you again.
Hi, thank you. So thanks for having me, Madam Chair, Senate Health and Welfare Committee members. I'm Beth Seitler. I'm the Executive Director at Champlain Community Services. We're up here in Colchester. I'm also the co-president of Vermont Care Partners. CCS is a specialized service agency, and we're also part of the 16 member designated agency system. CCS provides lifelong comprehensive supports for Vermonters with developmental intellectual disabilities. We also provide long-term care to aging or disabled Vermonters, and we run a site-based educational program in collaboration with 5 area high schools. Our specialty is supported employment, and I've worked in the field for close to 30 years now, shockingly. The developmental services directors and Vermont Care Partners are in support as well of H 720. And we especially appreciate the sections around quality oversight, residential expansion, and system oversight. Julie, I think we'll talk a little bit more to system oversight. So in general, the Vermont Developmental Services System is both a system in transition, as Susan, I think, illustrated, and we're also a system in crisis. Below are more of our specific comments on H 720. First of all, section 2, the system of care plan. Just want to note that DS directors realized that the recommendation for an extension of the system of care plan was really for our benefit to reduce the administrative burden that agencies were encountering. I want to acknowledge that and appreciate it. And having said that, we're not in any way opposed to the extensions being approved by the legislature in the future. I just think that the circumstances around the extension are certainly unique. Section 3 around quality oversight. Again, VCP members are philosophically supportive of enhanced and more frequent quality oversight. Agencies are proud of the work that we're doing, and in general, I think our reviews have been very good. We appreciate a mostly collaborative and a good relationship with the state. Rarely has it been sort of a gotcha relationship when it comes to quality service reviews. And we also understand that Dale has the responsibility to make sure that people are safe and that they're receiving good quality services. However, I think it's really important to note that quality oversight alone does not improve quality. Stability and investment in high quality, well-trained staff and quality oversight does. There just can't be good, reliable quality without good, reliable funding and stable staff. The unfortunate reality that we're facing is that in our historically underfunded system, either, and especially enhanced, I think, by the pandemic, is one where quality simply can't be sustained, not at the funding level we're at. And we don't want a situation where agencies are being, quote, kicked when we're already struggling to get up. Vacancy rates in DS remain incredibly high, higher than in other healthcare sectors, and even within our system of care, DS is showing much higher vacancy and turnover rates. There are so many new staff, and our experienced staff have been working overtime for a couple of years. There are fewer people now who work in services who really know the work. DS directors are frankly worried about burnout. And we're also worried about what happens when, I know as a director, I see this and worry about it, when there's that one person who holds the knowledge, if they miss an email or if they miss a phone call. What happens if that one person who has the lived experience in working in this isn't there to catch that? We're worried about the people in services, we're worried about our staff, and we're increasingly worried about safety. I don't like to admit that. It doesn't feel comfortable to me to say that, but it's simply the truth of the moment that we're in right now. Agencies around the state are closing programs as a result of a lack of staff. Residential programs, crisis programs, and frankly, that's because people just can't safely be staffed. I'll give you an example of CCS. Unfortunately, we were a pretty profound example of what's been happening in the system. Over the last couple of years, we were facing tremendous vacancies. In fact, last October, we were facing a 60% vacancy rate on our front line, 60. We were tremendously worried about quality. We were worried about safety. We didn't know how we were going to be able to get people the services that we need to provide them and that we want to provide to them. And this is on the heels of being one of the best places to work in the state for the past 3 years. In fact, just this week, we were awarded a 4th year in a row of being the best place to work. So I feel like we've been really doing our diligence and taking care of our staff. And yet what we were hearing from our staff is that they couldn't stay working with us. So our board of directors made, I think, a very brave, there's maybe other words for it, decision to increase pay to the front line at $3 an hour, and also with compression up through service coordination. I need to be really clear, we were not funded to do this. We knew that we had some vacancy savings and that we could do it for this year. And we also felt a special responsibility to make this decision to take care of the people in services. The effect of that was fast and profound. The departures due to pay stopped. People started coming back to work for CCS. And right now, as I sit here and talk to you, we have cut that vacancy rate in half in 4 months. So CCS, I think, is demonstrating, perhaps at our own financial risk, that it truly is about the money. And I want to note that I know that you're familiar with our ask for a 10% increase to Medicaid providers. First of all, it's not aspirational. We weren't looking to overshoot and settle somewhere in the middle. It truly was the minimum that we need to be able to make this work. I think if it's not able to be funded, we all need to consider what we're going to do less of going forward, because we can't do this work well if we don't have good, reliable staff. Residential, section 4. Again, VCP and DS providers support the pilot of new residential options and of the hiring of a residential coordinator. Housing and residential options are critical for people in the DS system, and the families coming together, and I think Susan illustrated this beautifully, pushing this effort are making an incredible impact. The proficiency that people are speaking about developmental services now. I think as a result of this family advocacy is vastly improved. It's exciting. This group is cohesive, it's organized and impactful. I know you've had good testimony from them. I've seen it. We also appreciate that they're working on collaboration opportunities with housing organizations. Many of the agencies would love to be able to have access to these opportunities as well. Again, Vermont Developmental Services Residential is in crisis. Agencies are staffing people with senior staff. Many people are in hotels. We've had a gentleman in a hotel for over a year. Directors don't yet know what's being presented by the family group, what the design idea is, but we're looking forward to hearing what it is, understanding how it will improve, respond to people's needs and costs. And we're looking forward to collaborating with the families around residential options. We want to make sure as well that whatever is designed continues to support the autonomy of people and services, and to make sure that people continue to have choices, because there still are choices within developmental services. You've been hearing a lot about shared living providers and needing options beyond them. And I certainly appreciate that. Full disclosure, my husband's been a shared living provider for over 11 years. I know how complicated it can be. I know how challenging it can be. And I also know how beautiful it can be and what a profound effect our shared living providers have on the people who live with them. Currently, there's, I think, around 1,350 shared living providers in the state. I think that represents about 75% of the residential options in Vermont DS. It's a very caring option, and there are so many successes about how this has worked for people of care needs across the spectrum. And as one director recently said, when it doesn't work big. And I absolutely agree. And keep in mind, the shared living system is flawed, and it has been historically woefully underfunded. On average, shared living providers have been paid between $25,000 and $35,000 a year, with some outliers for sure. That comes to about $68.50 and $96 a day. And the system of care priorities have narrowed, so the people coming into our system have higher acuity, which I think is also contributing to more transitions, not to mention the impact of a pandemic and lack of staff and lack of respite and lack of opportunities for people to get out. The pressure on this model has been incredible over the last couple of years. And while I'd say in years prior, it was beginning to show some cracks, I think the last 2 years have really split it wide open. One of the reasons that you probably know, or two of the reasons that we use the shared living provider model is, one, because we really want residential to always be community-based. We want people to participate and be a part of their community. And the other part is, of course, cost. It's about 1/6 of what a staff model is currently in the state. If you read my testimony, I won't go through all the different options that we have, but there are many options right now, new options that are happening around residential, some that are historic, like group homes, transition housing, roommates. We do a lot of staffing people in family homes, in their own homes. People have buy their own houses. And I have to acknowledge that we need new options to support people in the homes that they choose, either with peers or people who have heightened medical needs. We also need to solve the problem of people in services always being the ones to move when their housing falls through. There's so often, and I've seen this again and again, and it's heartbreaking for people to live in a home for a long time, and then somebody finds another opportunity and they're out, and we're looking for them. And I'm sensitive to how awful this is for the people we serve, and also to the families and their concerns about where does that stability come from. Housing stability in the state, regardless of what models we come up with, the only way they're going to be truly successful is if there's sufficient pay to keep the staff in place, regardless of if it's a new type of group home or community-based living or whatever it is. We need to have stable staff, and we need to have whoever the provider is being paid sufficiently to be able to live in that position. We need respite beds throughout the state. CCS had a respite bed for 11 years that closed due to pandemic this year. It was fully accessible, and it's a tremendous loss to we have 45 shared living providers. It's a tremendous loss to them. We also need to work together so we don't create an exclusive service model where people and services begin to be carved out of their natural communities. I know that's not the intention of anybody, but I need to have it said and make sure that we're really holding the line on that. Both the people in the community, all of us, and the people in services need to live together, and we need to be able to participate in each other's lives. And so I can't be supportive of anything that excludes that opportunity. We need options for people with high and complex medical needs. And then just a reminder, and I'll close now, is that Vermont DS isn't just about protection and safety. It's importantly about providing meaningful choice and options for people in services. People with IDD in Vermont have to have agency over their lives, as well as having robust residential opportunities, robust employment, education, community opportunities. The pandemic has brought terrible isolation to people in services, and we've worked so hard to help them, to help all of us to participate with each other in the community, and we want to make sure that we're holding on to that. The most essential way to do that is to assure them that we're going to take care of the people who are taking care of them, which means the staff. Thank you.
Thank you. That was very comprehensive, and we appreciate your support of the legislation that we're looking at. Hopefully it can solve some of the problems going forward.
So thank you.
Yeah. Okay. Questions for Elizabeth?
I have general questions, maybe for all three of them, if we have
Okay,
time.
we'll hold it until
Yeah.
Julie is finished, and then we'll have time for that. That'd be great. You want to ask a question now so they can think about it?
Well, sure.
Yeah.
The bill includes the money for the pilot programs. And I'm just curious about whether you feel it's sufficient, and I'm interested in trying to connect to actual housing funding, because this is obviously housing, and wondered if you had thoughts about that, and what you hear about what's going on out in the community. I know in my district what's going on, but sort of statewide, and whether or not the pilots are going to actually lead to real housing options or not.
So I'm good. That's a super question, and it would be great if each one of you could respond to it after we hear from Julie. So let's go to Julie. You don't have anything for us in writing as yet. I'm wondering if you.
I'm so sorry I finished it up this morning, but I will send it as soon as I'm done.
Don't apologize. As long as we know we're getting it, we're happy. Good.
Okay. Well, thank you. For the record, my name is Julie Cunningham, and I'm the Executive Director of Families First in Southern Vermont. And we're a specialized service agency that serves children, youth, and adults with disabilities. And I'd like to thank you for taking this testimony on H720. A caveat, I am going to echo things that Susan and Beth said, because we're like-minded friends and colleagues. So apologies if I'm repeating some of what you just heard. I'm very grateful to you all as our legislators.
Julie, I'm going to ask if you could possibly get either closer to your mic,
Sure.
Because we're having. You just disappeared.
What just happened?
Is your video went out?
Yeah, can you hear me? I don't know what just happened.
We can, but it's still like sounds like you're in a little echo chamber.
This has happened before when I'm. Hold on just 1 second.
Julie, why don't you go ahead, and then we'll look for your written testimony to fill in any of the gaps.
I've been on.
You still have it, just your
I know, but why did it go?
When we get back, when she gets back. Julie, why don't you go ahead with your testimony? If you can get your video back, that would be great.
I'm just going to join on my iPad. Can Aaron let me in? I'm gonna
Aaron,
join on a different
yeah.
device.
Yeah.
She needs to leave with that device or it's gonna.
Okay, I'll leave this one. Let me just- It's just completely stuck.
Okay, you're back.
So sorry.
Oh, this is great.
Much better.
Terrific, thank you.
Okay. For the record, my name is Julie Cunningham, and I'm very grateful to you as our legislators that you have been working diligently to understand the developmental services system, a system that Representative Wood has said is in crisis. It very much is, and I see the frightening evidence of this every day. The pandemic amplified the isolation that people with disabilities already lived with, and many are suffering with depression and anxiety. Our shared living providers and families have been carrying a too heavy load since the beginning of Stay Home, Stay Safe, caring for extremely vulnerable people who need a high level of care. Many are nearing a breaking point and need respite desperately. Because the people I serve depend on direct support professionals for their health, safety, and to access the community, the workforce shortage has caused a triage situation at my agency. We meet every Monday morning to sort through who takes priority for our limited pool of staff. This changes moment to moment as we are impacted by illnesses, COVID exposure, children who are quarantining, and burnout. Our vacancy rate is hovering around 25%, down from 35%, but this still means that too many people don't have enough services. My case managers are covering cases and can barely keep up with their electronic health record documentation. Our 24-hour crisis bed was full for a straight 18 months with people experiencing acute mental health emergencies, which led to 75% of our crisis team quitting. In my 22 years as director, I've never been more worried about our system. This is the backdrop to payment reform efforts, which I understand are necessary to comply with Medicaid regulations and the 2014 auditor's report. However, payment reform cannot be Dale's singular focus when our system of care is as fragile as it is now. There have at times been 4 work groups for payment reforms, and yet there's not one addressing the high acuity of people in distress, individuals who can't access mental health care and or who are homeless. Agencies have been asked to get DS people out of emergency rooms, but we aren't taking a deep dive into what would de-escalate or prevent the lead up to this devastating outcome. The family stakeholders who are asking for more housing options have been asking for Dale's systemic support for a long time. I have been having these conversations at my agency for 20 years. This section of the bill is an important first step in addressing the need. Having a Dale employee dedicated to developing residential programs and the pilot planning grants will certainly help to alleviate the stress the lack of options is causing. I'm hopeful that the steering committee can ensure equity because I am concerned about people like young adults who age out of DCF custody, who have a limited advocacy voice, and who also need creative housing supports. I am in support of the annual on-site quality assurance reviews to ensure the health and safety of vulnerable people and services. However, I must say quality is negatively impacted by the chronic underfunding of the DS system, which has led to turnover and chronic understaffing throughout the state. Without a trained, qualified, and well-compensated staff, reviewers will find problematic situations that can and should be avoided. This is why Vermont Care Partners' ask of a 10% rate increase is critical to address the fundamental issue that impacts an agency's ability to meet the gold standard of care that we all want provided. I know that Bill H-153 is addressing funding, and I hope you will consider the need to link these funding targets to the goals of H-720. From my perspective, the most important part of the bill has to do with legislative oversight and payment reform, including the new assessment of procedure and conflict-free case management. The reform process up to this point has unfortunately been, for the most part, a series of top-down decisions that have been made without meaningful stakeholder engagement, which is a Medicaid requirement, and then it is reported out and defended in meetings. There have been limited opportunity to shape the policy or factor in key learnings that only come from lived experience. There has been a groundswell of agreement, at least in Southern Vermont, that the process thus far is leading towards system changes that have excluded the most important people from the dialogue, the ones that will have to live with these changes. 3 weeks ago, I heard from parents who felt that the Dale response to the Windham County Stakeholders Group's letter to them about their concerns was dismissive and did not answer their questions or assuage their fears. This has been my observation from the beginning, and we must work against an ends justify the means mentality. It may be that because of the pressures around timing, Dale is moving through reforms with a sense that as long as we get to a final product, it doesn't matter as much how we get there. I think you as legislators understand at the granular level that process is as valuable as product, perhaps even more so when the stakes are this high. I don't want to minimize the way the pandemic led to an interruption and subsequent confusion in payment reforms. But the problems with process have also been a result of the high turnover at the division. Besides many long-term and dedicated division staff that have left or retired, there have been 9 directors in the past 12 years, 6 in the past 6 years. If this was one of the DAs or SSAs, we would rightly be on a corrective action plan. We all know that rapid turnover leads to instability with any group or process. I think the current director, Jennifer Garabedian, is a great hire. I've worked with her in different roles for many years. But an official reset on the process needs to happen, including a definition of what meaningful stakeholder engagement means. Here's one. Agendas and meeting materials in plain language are sent out ahead of time, and opportunities for feedback are genuine and not tokenized. By that, I mean that people with disabilities, family members, and providers are listened to and are there to legitimately guide and shape policy. Again, I'm not speaking about the have-tos, the things we must do to be in compliance with state and federal mandates. I'm speaking to the parts that have allowances for our state plan, for nuance, amendments, and where we have the ability to meet Medicaid requirements with our Vermont values at the forefront. Since this is what you, our representatives, do each session, and the fact that most of you have been contacted by numerous disenfranchised and scared self-advocates and families, it makes sense for this body to provide the needed oversight. We all understand that debate, disagreement, and compromise are an integral part of any transformational change. The stakeholders I am in contact with, as well as my Vermont Care Partners colleagues, are ready, willing, and able to participate in a respectful and goal-oriented process, knowing it may be challenging at times. We know that transformational change is what our DS system has in front of us. I have no doubt that Bill 720 passed in its entirety will bring the needed transparency, guardrails, and oversight to the reform process and to the developmental services of care. Together, we can do hard and important things while protecting our most vulnerable Vermont citizens and enhancing their lives as integral members of our communities. Thank you.
Well, thank you. That was very helpful, and appreciate you're getting the sound right.
Sorry about that.
But
it's on my desktop. It has a time limited and then it just stops working, which I forgot.
Oh, well. So, and please do get your testimony in writing to us. You can send it right to Aaron and then we'll have it for the record.
Absolutely.
Terrific. Questions? Now, Senator Hardy has asked a question for all of you. Why don't we give you a few minutes to respond? We've got about 5 or 6 more minutes for testimony from you. So do you want to briefly remind them of the question?
Yeah, just about the pilot program and whether you see that as an effective, I think Beth, you mentioned it, one of you mentioned it in your testimony specifically, but and whether the $100,000 for the pilot will be sufficient to actually have anything happen. I'm a little worried about not some pilot, studies happening and then nothing, no housing actually being coming from it. So I guess just your general thoughts on the pilot section of the bill.
Yeah, thank you. I'm not sure. Is the $100,000 seems a little unlikely to build what I think probably needs to be built from what I see. You know, if it's, I can't remember if it's 100,000 for each house or if it's 100,000 for the 3 pilots. The bricks and mortar part is significant. We all know that $100,000 isn't going all that far these days in Vermont, you know, given what's happened to real estate. So I think, but I think it's a start. It's a start to begin to lay out the process. Hopefully the collaborations with housing authorities will help with some of this. I think it'll get individuals, it'll at least, I think, pay the salary for somebody to really investigate how we go forward on it. But I don't know. I mean, for me, there's the startup cost, there's the one-time money, and then it's the ongoing dollars where I get concerned about how it will be sustained. And we still, you know, I'm not quite sure what the model is yet. I'm looking forward to understanding it and talking to parents, to the parents in the group, to hear what they're imagining. So sorry, I can't answer any better than that.
I'm looking at our spreadsheet with the budget information, and it looks like the $100,000 is a limited service position, and then there are additional funds to develop the pilot planning grant. So there is more money,
Okay.
as you indicated was necessary, that's there. But we'll see, you know, we can't predict what happens during the budget process, but there is some there right now. Why don't you go ahead, Susan, go ahead, and then Julie?
I would just say, I'm not certain what the right amount of money is to be able to set up a pilot and to test it out. I think it probably has some regional variations. Certainly there are more expensive places and less expensive places in Vermont. But I guess I worry that if inadequate amount of funding is provided for the pilots, then they will fail, and then this will be evidence that it doesn't work.
Right, good point.
Exactly. I'm concerned about that too, Susan.
Julie, did you want to comment?
Yeah, I would just add that I know that several of the families that I work with here at Families First are concerned about their family members with very complex medical needs. It often, the needs are often too complex for a single shared living provider. So really needing to be thinking creatively about how we can address that. I know that some of the things that are out on the table, like the Heartbeat Shared Living program in Hardwick, they don't take people with complex medical needs. And so I think that's been another really difficult thing for family members around lack of choice. And then I will also say we work a lot with kids in DCF custody who also have a disability. And I really worried about that population. They don't have strong families advocating for them. A lot of times for those youth, they're done with the system when they turn 18, but they still need supports. And we could really use housing vouchers and things like Succeed, the program out of Howard Center, which is a dorm living opportunity, and to pursue higher education at the same time. But I've long thought that it would be great if there was a dorm-like setting that was learning about life and launching and kind of doing some reparative work with youth who have missed so much over the course of their lives. That's just a little fantasy that I have. I might be the only one who has it.
Well, that's really interesting because there's dorm space in our state colleges that is vacant, and that could be a really interesting model. Maybe that could be one of the pilots, Julie.
I'd go for it, I
Idea.
promise you.
There you go. Okay, well, thank you, each one of you, for taking the time to provide information to us this morning. It's been very helpful, and we appreciate that. So we're gonna move on to our next topic, and knowing that you've really helped us understand and work toward the end of our decision-making on H720. So thank you very much.
Well, thank you all so much, and thank you for all your hard work. It's much appreciated.
Yes,
Thank you. Okay. All right, so we're gonna step back to, oh, by the way, you know, we got the new spreadsheet from Nolan, but I wanted to urge you not to throw out the old one because it has, on the front page, it has all our bills on it. And I think the new one doesn't have that there. I noticed you threw it out. Throw it out. That's where I found the H720 on that front page. Okay, so, Jen.
Yes.
Here we are. We're on 266, and there's a little ambivalence going on about keeping that last proposal in on the DSCA. But I think what I'm hearing from folks is it would be okay if we did not add that into our amendment. We might, and I think we might encourage, I think Senator Hardy indicated that you'd be fine with taking it out, but it would be great if DSEA and NEA would consider this, so I'm of the same mind.
Yeah, I mean, I don't want to hold the bill up because of it.
Yeah.
I do think there's some hypocrisy of us requiring everybody else to do it and then not doing it ourselves, but I would assume that I would hope that they would both be on top of it and put it on the table at their next negotiations.
Well, I'm also gonna suggest that our Government Operations Committee look at this amendment and see if there's anything they want to do with it or think that can be done with it. What is the thought of, what is the committee thinking here? I'm just looking at section 5 on page 3 of draft 2.1, the proposed amendment for H266.
We can strip it out.
Yeah.
Strip it out, just.
Okay, yeah, I think we'll do that. It would be great to take a whole lot of testimony.
Yes.
Are you okay?
Yeah, he didn't know we were still on.
Oh, okay, all right.
I've never noticed there's like a never ending screen thing. Our screen is on screen and then it's on screen again and then it's on screen.
I was looking at that the other day.
And our rule has developed an angle.
The room has got really strange Esser angles.
Yeah.
Is it?
Escher.
Escher, thank you. I've got
Elementary and
Esser.
secondary.
Thank you, Jen. Okay, so Jen, how difficult is it to take that out of the proposed amendment? What
Not
does
at
it?
all.
Huh?
It's not at all difficult.
Does it do anything to the rest of the bill, just taking it out?
Nope, because we won't renumber the existing section 5.
Doesn't do any renumbering?
Nope, doesn't, right, it just.
It just goes back to what the bill was originally as far as what that,
Right, you're just not adding, you're talking about adding a section, you're not adding a section, it's, you just keep the rest of your amendment. And I keep going around and around in the other amendment. I think I want to make it change that I don't think anyone will care about. But to say about the limitation and the 3 years and then requiring the plan to cover the cost of one or more new hearing aids prior to the expiration of the 3-year period rather than a 3-year period.
Oh,
Just so
yes.
that's
Okay,
It's
technical correction here.
Exactly. So I will make those changes and we will call it 2.2.
Okay,
I don't know if you need to.
but
see it.
why don't we just wait for you to do that, Senator Cummings?
No, I was gonna make a motion.
Oh, well, go ahead, and then,
I'm gonna move that we amend H266 as shown in draft 2.2. And that's the first through the fourth instance of amendment.
Yes. Okay. Oh, I need to take out the
With that
highlighting.
D and A change, but that'll be.
whatever she
And
said,
it'll be-
right?
it'll be clean. I'll take out all the highlighting.
All right, so now discussion. This is great to get to this point after so many years. Okay, no discussion. Senator Tarantini,
Senator Tarantini, yes. Senator Hooker,
wait, let's make sure we're voting on draft 2.2.
2.2.
Yep, okay.
Got it there. Senator Hooker. Yes. Senator Cummings.
Yes.
Senator Hardy. Lyons.
Yes,
5-0-0.
now we need a motion.
Move that we approve the bill as amended. H266.
Okay, discussion?
Tarantini's yes. Senator Hooker.
Yes.
Senator Cummings.
Yes.
Senator Hardy.
Yes.
Senator Lyons.
Yes, terrific. That's great. Who would like to report?
Or,
Yeah. Okay, I'm happy to report.
you worked on it for a lot of years.
Well, yeah, no, everybody cares about this one.
This is a happy stuff.
Okay. All right, we'll do that.
I'm gonna do insurance and banking.
You're doing reach out, you know that, right, when we get to it.
Yes.
Yeah.
Because I get through captive house.
So, but remember, I've worked on a lot of these bills for many years, so you know, it doesn't matter. I think it's just important that everybody have an opportunity.
I have other bills that we haven't passed yet that.
I can tell, I know, me too, me too. All right, so. Is it done?
It is done. I sent it to Erin.
Aaron has it?
That's very good.
Okay. Sure, we don't want to get out of here before that. Right. What do I take upstairs? Just the amendment.
The amendment and the bill,
And the
these
bill.
are not strike-alls. The amendments for today are not strike-alls.
You have to take yours. And this is 266, and we're gonna look at H720. Any, you know, the other bill that we need to look at again, and people have been reaching out wanting to testify, is the 353 PEM bill. So as I said the other day, try to get some clarity on your thinking and the information that we've heard, and maybe reach out, call a friend, and then we'll pick that one up again as well.
It's uploaded. It's uploaded.
Okay. Have it. And then we've got H720 to consider with, when we get Katie back in to look at that bill one more time. I think we've had sufficient testimony on that.
This is the bill that, you know, in that constituent of mine said I was gonna call them, and you said that was,
We'll talk about that. Yeah, we're still.
well, I have many constituents, so.
All right, so I think we can go off you too, Aaron. We're pretty